the evaluation of the community perception tracker for COVID-19 response in 2 countries. The project is a collaboration between a range of implementing and research partners in Lebanon and Zimbabwe, and is funded by ALRA. The rationale for conducting this research is that we recognize the need to strengthen community engagement, but across the sector, we're still weak at doing this systematically and in a way that leads to meaningful programmatic improvements. We know that community engagement is a key pillar of outbreak response and that the COVID-19 pandemic provides an opportunity to do better. CPT presents a way of addressing these challenges, but we have no evidence that it works or that it's feasible in outbreak response. Oxfam developed the CPT, so the Community Perception Tracker approach during the 2018-2019 Ebola outbreak in DRC. And the approach is designed to systematically collect qualitative data on perception so that response programs are tailored to people's preferences, needs, and understanding. The process is intended to be to work through 6 steps, like you can see on the screen. The first step is data collection, and for this, programmatic staff use mobile devices to record qualitative information on perceptions, fears, questions, or concerns that people have in real time when they're voiced during program activities. So, for example, community meetings or trainings. This information is then uploaded to the Survey CTO or Kobo platforms, and then they generate anonymized and accessible reports, which are then analyzed, which is the second step. The analyzed data is then discussed in regular meetings and triangulated with other actors. These findings are used to adapt activities or are also used or can be used to influence or advocate for change. And lastly, there's a follow-up of activities. So we're conducting a process evaluation of the Community Perception Tracker. And so we're documenting how the CPT is implemented and what was actually delivered compared to what was intended to be delivered. And so we're tracking the implementation of the CPT against the theory of change. So if the CPT is implemented as intended, it would lead to Oxfam and ACF staff being able to learn from populations in real time, and they would be able to use these community insights to adapt their programs. And this in turn would lead to programs being more acceptable and relevant, and also address contextual barriers to preventative behaviors. And finally, this would lead to the adoption of COVID-19 behaviors by the population. Our research aim is to understand whether the Community Perception Tracker approach can effectively help COVID-19 response organizations to adapt their interventions so that projects are delivered with quality and are seen as relevant and acceptable by populations. A link to that aim, we have 3 objectives. The first one is to understand how community perceptions change over the course of the outbreak. And for this, we're collecting CPT data on an ongoing basis. And if you're interested in finding out more about the CPT data and some learnings on the process, a colleague from Oxfam is presenting a poster on that on Tuesday. The second objective is to understand whether the CPT enables staff within humanitarian organizations to make more informed decisions and adjust programming. And for that, we're conducting qualitative interviews with CPT staff at 3 time points in both countries. And we're also supplementing that with data from logbooks and reports. And the third objective is to understand whether the adjustments made to COVID-19 response programs are more acceptable to communities and result in behavior change. For that objective, we're conducting repeated phone interviews with affected populations exposed to ACF and Oxfam programs. And these interviews will also enable us to understand community perceptions through an alternative method as a means of comparison to the CPT data. So today's focus is on the qualitative interviews with CPT staff, and so far we've conducted 15 interviews with 15 staff members at 2 time points, once at the beginning of the project and once around the middle. These were unstructured interviews which took between 30 and 60 minutes and were audio recorded and transcribed for analysis. So as I mentioned, the study is being conducted in Lebanon and Zimbabwe. In Lebanon, Oxfam is working with their partner NABAD in refugee populations in 2 sites in North Bekaa. They're conducting wash and protection programming. And in Zimbabwe, Action contre la faim is working with their partners Africa Ahead and Nutrition Action Zimbabwe in 6 provinces, and they're conducting wash and nutrition programming. So our project is still ongoing and will go on till the end of September. So I'll be sharing some initial lessons learned about using the CPT for outbreak response. The first finding from the CPT staff interviews was that it took a while for staff to understand that this was not an active data collection, but rather active listening. Several CPT staff viewed it as a survey in the first round. So this quote from Zimbabwe says, "It did take a bit of time for people to really appreciate that this is not a survey." The second finding was that training was reported by CPT staff in both countries as needing strengthening to understand the full process. The initial training sessions focused primarily on the CPT data collection rather than how it would be analysed and used. Some staff expressed the need for regular refresher trainings as well. So the first training missed a lot of things. Everything was vague. No practical work was done at that time. We did not know where the data was going. And that was a quote from a CPT staff member in Lebanon. The capturing perceptions was also a challenge, especially because of different priorities with work, and entering perceptions accurately and classifying them to enable analysis was also challenging. And staff also had competing responsibilities, which reduced the number of perceptions they were able to collect. The analysis part of the process was not really explained in materials or training, and was a skill that was that the staff felt unfamiliar with. This resulted in teams developing their own approaches to analysis, and there's a need for this process to be strengthened. Originally, the CPT was also intended to involve multiple program staff in analysis, but this has been challenging in both countries. And there were also some gaps lags between data collection and analysis at the beginning. The CPT staff recognized the importance of the regular team meetings, but they took a while to get established in both countries, and there were differing opinions on how frequent these should be held, and also differing levels of engagements within teams. This quote from the Zimbabwe, from a member of staff in Zimbabwe says, "I think the meetings have been quite interesting. It's always good to hear how perceptions differ, according to region, and I think also the sharing of experiences has actually, helped us to address some of the challenges we were facing, or actually to be more aware of them based on the experience of other staff members as they share during meetings." Acting on insights was also challenging. This was because of limited human resources and the pressure of the pandemic, which made it hard to prioritize summarizing, reflecting on the data, and acting on insights. Regular team meetings proved an effective way of overcoming this, but having a template to document emergent insights, specific actions taken, and track follow-up of these actions is likely to be key for monitoring the process in the future. The CPT often generated insights that related to things that were beyond the scope of the ACF programs. For example, this could relate to government trust, mental health, protections, and livelihoods. So in this quote from Zimbabwe, says, where the challenge then comes in is where probably some of the modifications require a higher up level. For instance, when we talk about stakeholders from the Ministry of Health sharing for more information about the vaccine, we can recommend that, but we cannot really control, because the aspect of information communication is governed at the Ministry of Health national level. The CPT staff reported buy-in from managers and key stakeholders. This was through sharing the CPT process with local actors, and but effective use necessitates engagement from managerial staff within organizations in order to endorse the process, the value of the approach, and the necessary programmatic changes. Recommendations based on the CPT data were shared with stakeholders at several time points through meetings or reports, but it's unclear whether those actions are acted upon at the moment. There's no feedback loop. Generally, the staff felt positive about the approach and felt it made the process of community engagement more systematic and helped them to justify programmatic action. Staff felt that the CPT positively affected their other work and it got easier over time. However, they recognized that the approach is time consuming and they felt it was necessary, they felt it was a necessary part of community engagement. When the CPT came, I said to myself, this is one of those things that I have to do. But now that we have realized the potential in the tool, for example, informing future programming, we are taking the CPT more seriously than before. This was from a CPT staff member in Zimbabwe. We get more referrals for protection and we are able to do our work better based on these perceptions. And that came from a CPT staff member in Lebanon. So last finding is that it seems that the CPT is well placed to understand what communities are thinking during the outbreak, but is less well placed to act as an accountability mechanism, which can pick up issues in program design and acceptability. So in the coming weeks and months, we'll be conducting our last few rounds of interviews with populations and analysing that data to understand acceptability and relevance of programs. And then we'll also be doing one more round of interviews with CPT staff, which will include questions to address remaining questions about the process and more about experiences of using the CPT, among other things. We wanted to share a few reflections of doing research during the COVID-19 pandemic. We found value in doing what we're calling a phased process evaluation because the pandemic was so unprecedented that it didn't feel like it made sense to share research finding at the end of the projects only. So we adapted our way of working to build in learning workshops. And at these 2 workshops, we discussed findings to date so that implementing partners could define a key set of actions to work on for the next period. We work closely with local research, local academic partners, and this facilitated ethics agreements, but also added a local independent research perspective, which can provide more nuance to results and strengthen the validity of the findings, and also fosters relationships between operational and academic partners locally. We emphasized building local organizational capacity for research, and by having trainings that included research principles and analysis techniques, and we'll be doing the analysis and the write-up collaboratively. Remote data collection presented a number of opportunities, such as being efficient, because we were able to do several interviews per day and transcribe them on the same day, for instance. It also enabled longitudinal involvement with the same participants by calling them over several rounds. However, it also had challenges such as difficulties in reaching participants due to network or power challenges, and phones sometimes being shared with household